We are thrilled to have you join us on day 3 of the 5th annual meet of the Indian Myeloma Group. We begin with our CME talks for the day. Our chairpersons are Dr. Narayan Kuti Warrior and Dr. Prantar Chakrabarti. Dr. Narayan Kuti is Medical Director and Senior Consultant at MVR Cancer Center and Research Institute, Calicut. Dr. Prantar is Director, Hematology and BMT at AMRI Hospital, Kolkata. I invite our chairpersons to the dais to introduce the speakers.
Good morning, everyone, and happy Pongal and Magara Sankranti to all. This session is basically we all are looking forward newer directions in multiple myeloma. The first speaker is none other than Nupur Raj, and she doesn't require any introduction. Over to Dr. Nupur.
Good morning, and thank you very much. What I will be talking about in the next few minutes is the immune system, immune reconstitution, and vaccination. And I think these are really incredibly important topics in the context of myeloma, specifically given that we are living through a pandemic. The pandemic is still not over. And second is, with all of the fantastic immunotherapies that you've been hearing about, I think the impact on using our immune system to the best possible capacity is critical, and for that, understanding the immune system is equally important. Here are my disclosures. And really, as mentioned, we live in a very fortunate space in multiple myeloma. We've seen a tremendous amount of progress, and despite the fact that we've had a pandemic for the last 3 years, we've actually had 3 immunotherapeutic strategies approved. We've had 2 CAR T cells, and we've had a first-in-class bispecific T cell engager, as well as an antibody drug conjugate approved in the last 4 years for myeloma. So incredible progress, but with this progress, I think it comes understanding some of the toxicities, understanding how best to manage these patients is important, and to do that, understanding our immune system is important. So the immune system is not something which is new to an oncologist. This is something we've studied for many, many, many years, and T cell energy has been a very important part of why people, specific people, end up developing cancers, and not everybody else develops cancers. And I think it's critically important to myeloma, given that it's an immune, so it's a cancer of the one of the immune cells, which is the plasma cell. So understanding this is important as well. Again, there's a lot of parallels that one can draw from the cancer world and from the infection world, and specifically chronic infections, where you will see T cell exhaustion patterns, impacts on CD4, CD8 cells, and some of the T regulatory cells as well, which we'll try and put in the context of myeloma. Now, with this, obviously, there is a risk for infection, and that risk of infection is it's changed over the times, and in the context of novel therapies, it's important for us to understand. And this is data from, it's almost like a registry data, looking at patients without cancer, and then patients with cancer, and then patients with different in different cohorts based on different treatments. So the risk of infection hasn't gone away. It's just that the risk of infection over time, depending on what kind of treatment you're getting, that risk changes. And that's something we're going to talk a little bit about. I'm not going to go into too much of detail on infection, because I do know there's a separate talk on how do you treat these infections in this context. And why is this important? This is important because obviously people are still dying from infectious causes, and specifically so in the cancer world, these mortality from infection is not trivial. So again, when you think about immunosuppression, and now focusing more on myeloma, the spectrum is from minimal immune suppression, and one can have severe, significant immune suppression. And we have this precursor disease state of MGUS and smoldering myeloma, where the immune system is fairly intact, whereas severe is where you're using high doses of chemotherapy, or you're using sort of myeloablative chemotherapy. And even in the relapse refractory setting, with some of the treatments that we have, you can end up with severe immune compromise. It could be disease related, and it could be treatment related, and it could be a combination of the two, and I think it's important for us to understand that as well. So just a few words on the immune system in general, and specifically in myeloma as well. Within the immune system, you have cells which are tumor promoting cells, so the myeloid-derived suppressor cells, for example, T regulatory cells, the plasmacytic dendritic cells, and there's more and more preclinical work on all of these tumor promoting cells. There is obviously data with the anti-tumor cellular immunity, and this is something which we really used and honed in on to try and develop some of the novel treatment strategies, including with, and you will hear more about things like NK cells, where we're doing CAR T cells with NK cells as well now. So again, impaired and deregulated T cell immunity is obviously seen in multiple myeloma. It's actually seen very early in the precursor disease states of smoldering myeloma also. And I think we've studied the precursor diseases quite a lot in the context of the tumor cell itself. But now there's more and more data looking at the microenvironment and specifically the immune system as to this being a risk factor for the progression of developing myeloma. So understanding the effect on cytotoxic T cells, understanding the effect on exhaustion of these T cells is really important in terms of biology of myeloma and progression to more aggressive forms of myeloma, and also when it comes to using some of the treatments that we have for this disease with respect to anti-tumor effect of this immune system. So when you think about the function of immune system, you can kind of divide it up. You can have T cell exhaustion, that could be disease related or treatment related, T cell energy, that could be baseline and also treatment related, and over time, and also given that our disease is a disease of the older patient population, we do from treatment as well as from age and other comorbidities can see T cell senescence, which impacts the risk of infections in this patient population. So you have all of these competing things, T cell dysfunction, which we do see in the context of the bone marrow microenvironment, more so when patients have active disease. So the best way to counter that is control of the disease course is really important. And as patients get multiply relapsed, you will see that their T cells tend to get exhausted, and that's part of the reason why when we talked yesterday, moving some of these immunotherapeutic strategies earlier may be of benefit. Differential T cell profiles have been noted, and this has been looked at in the context of prognosis from a disease standpoint and also from the risk of progression from these precursor disease states to active disease. So why is all of this important? It's important because we are also in the context of drugs. I showed you that timeline of drugs, and we talked a lot about drugs like daratumumab yesterday. And we do see the effects of daratumumab on the immune system or any CD38 monoclonal antibody. Example I've used is daratumumab. You're going to see the same effects with isatuximab because CD38 is expressed not just on the myeloma cells, it's expressed on the T cells as well. And what you see in patients who are on drugs for protracted periods of time with daratumumab is a low absolute lymphocyte count. I think this is important specifically if you're thinking about doing cellular therapies or bispecific T cell engager therapy post drugs like CD38 antibodies, we see decrease in CD4 cells. And what we have seen is different types of infections. We've seen viral infections, bacterial infections, and also fungal and parasitic infections, which were not being seen in the recent past, have now started re-emerging in the context of some of these drugs. Similarly, we have a lot of work which we are doing using BCMA-directed strategies. Now, BCMA is a protein which is expressed on all plasma cells, and plasma cells we know are antibody-producing cells. So it's a very important part of your immune system, and when you're targeting this, you're getting rid of that immune response in these patients. So if you look at some of the data now, and this is data from the IDACEL Karma study, if you look at data from here, these patients in the immediate phase can have neutropenia, thrombocytopenia, and the risk of infection, although not very high, any grade was about 70%, grade 4 was quite low, but these patients can be prone, at least in the first month post-CAR T cells, to these infectious complications. Similarly, with cilta-cel also we've seen very similar data, and in fact with bispecific T-cell engagers the story is very different. Here I've just picked teclistamab only because this is the one which is now approved in the United States, and the difference here is because we are giving this chronically and continuously, we did see a rate of any grade of infection of about 76%, and the rate of grade 3 and grade 4 much higher than with cellular therapy, so grade 3 and 4. Granted that we were using these drug products in the height of the pandemic, we saw a lot of COVID-related deaths using bispecifics, but even so, we are seeing sort of different kinds of infections when we're using these bispecific T-cell engagers, and one of the reasons for those would be constantly engaging the T-cell and causing exhaustion may be predisposing to these different infections. So infection prophylaxis is really critical in our myeloma patients, and to prophylax these patients, I think it's important to risk stratify patients, and therefore having a basic understanding of the underlying disease, comorbidities, and what is the treatment that you're giving, as well as any predisposing genetic factors a patient might have, is critically important. And infection prophylaxis cannot necessarily be one size fits all, but one would have to do it different for different patients. In terms of vaccination in myeloma, I think again a really, really important topic, and it's a topic which our primary care physicians always want to know exactly what to do. And the issue with vaccination in myeloma, so the problem here is we do not have good data. We do not have good prospective studies with vaccination. What we do know though is that vaccination cannot do harm. We do not know whether it can absolutely benefit a patient, because depending on the disease state of a patient, whether or not a patient will mount an immune response remains a question. But vaccination is important, and not just vaccination of the patient, but vaccination of close contacts is also critically important. I think there are a few principles that you can go by. One is obviously you want to avoid live vaccines, and I've just listed those. We do have a new zoster vaccine now, and that Shingrix, we call it Shingrix in the US, that can be used in patients with myeloma. The old Zostavax was not allowed to be used, and some of these live vaccines should not be used. In terms of precursor disease states like MGUS and smoldering myeloma who are not being treated, they should be almost considered as normal individuals, and they can be vaccinated without problems. Again, principles of vaccination, as I've already mentioned, all myeloma patients should be vaccinated. Vaccination of close contacts so that you avoid the risk of infection in the patient themselves. We do vaccinate for the flu, and what we've started doing based on studies which Andy Brannigan from our group has done using the flu vaccine, wherein instead of giving just one dose, the study here, his study was called the Shivering trial, an apt name for a vaccination study, but what he showed very nicely was with one dose of the flu shot, you mount an immune response, but when you get a second dose of that flu shot, at least in myeloma patients, the immune response was a little bit higher. So what we've started doing at MGH at least is when flu season starts, October, we give them their first shot, and then we repeat a second shot of the high dose flu shot sometime in January or so, and this is part of our new guidelines. Pneumococcal vaccine is recommended. We give both Prevnar as well as the other pneumococcal vaccine in patients. This is just a list of all the vaccinations. So pneumococcus should be given to all patients above the age of 65, and in fact anybody who has myeloma, giving them the pneumococcal vaccine is important. I've already talked about the flu shot and these others, meningococcal tetanus, DPT, and post-transplant. Actually, once you've had a transplant, 6 months post-transplant, we need to revaccinate. Similarly, once patients have had CAR T cells, we wait, instead of 6 months, we wait for about 3 months, and post 3 months, we start revaccinating them post some of these treatments as well. This is just highlighting which vaccine should be given and how often should patients be given this. So when does one vaccinate? Again, really important question and practical. So for you, again, you have to individualize and you have to look at the risks and benefits of when you can vaccinate. In general, things like the flu shot, you just give it to them every year. It doesn't matter what their disease state is. The one caveat is you don't know for sure that it's going to work in patients who have very active newly diagnosed disease or relapsed disease. If a patient is actively getting chemotherapy, we try and time the vaccination a little bit away. Specifically in patients now, we don't use as much chemo, but if they're getting drugs like daratumumab, and if they finish their weekly DARA and getting it, say, once a month, we do it sort of week 3. So you can pick a time to try and optimize the use of that vaccination depending on what kind of treatment you're using in a patient. Do we assess serological responses in myeloma patients? And the answer to that is not. We do not. And the reason for that is it's an expensive test. And even if they didn't mount a serological response, would you not vaccinate a patient? Because serological response is just one arm of the immune system. There's a whole T cell component to that immune system, and you're really not measuring that by just measuring serology. So typically we don't do it. In certain situations, when you do a clinical study, for example, we've studied it like Andy did it in his flu vaccination trial, but generally looking for serological response is not recommended. We've done it with COVID-19, and I'll show you some of the data here. But again, as mentioned, I think risk-adapted infection prophylaxis is key. Trying to identify where your patient falls, low, intermediate, or high risk, depending on what level of immunosuppression, disease status, and what kind of treatment they're getting. Then you can come up with your bacterial, fungal, or viral prophylaxis. In general, I think most of our patients are on antiviral prophylaxis, so everybody almost always gets acyclovir or its equivalent. A lot of our patients now, we've started putting, I never used to use a whole lot of PJP prophylaxis, but after using some of these bispecifics and things like that, I think I've started using PJP prophylaxis more so now. I didn't used to use it. And the last one is fungal prophylaxis. Typically, most of our myeloma patients don't need it, except if you see prolonged neutropenia. And with some of the bispecific T-cell engagers, we are seeing that, and we are incorporating even antifungal prophylaxis. I think a really important point, specifically when we're using B-cell directed strategies, like these anti-BCMA directed strategies, is immunoglobulin replacement. So we typically see IgG levels of these patients, and a lot of them will have immunoglobulins less than 400. And these are patients where we have been pretty proactive about replacing them with IVIG. With that, we are seeing a lower incidence of infections. Immunoglobulin replacement could be intravenous. You could even do the subcutaneous version, and we, at least in the US, have home IVIG programs that we can use, and we are tending to use more of this in the last several years with COVID and with some of the B-cell directed strategies that we are using. I think this I've already talked to you about, bacterial, fungal, and viral prophylaxis. So last few minutes I'm going to spend on COVID-19. We've all been through sort of an incredible time in the last 3 years, but the good news is we've learned a lot. We've gotten several vaccines which are approved and in record time. And in addition, we have not just different antiviral drugs, but we also have antibody therapies which have been tried and have been somewhat useful in some patients. So these are just the common symptoms. I think all of you are familiar. I think all of us have seen our patients go through this. We are physically have gone through it ourselves as well. And does it make a difference between cancer and do patients who get COVID-19 and cancer do worse? And the answer to that, compared to the normal population, obviously our patient population is more immunocompromised. So yes, they do worse, but what about COVID-19 and myeloma? And the International Myeloma Society under Nikhil's leadership actually did a lot of work early on with COVID-19, where we were seeing a lot of infections in patients with myeloma. And what we saw, interestingly, was that the mortality was a little bit different based on countries, and it could be related to the kinds of treatment they were getting as well as vaccination strategies as well. I think all of that has changed. We did see a lot more mortality. Even within the US, we saw regional differences. For example, the New York state and New York City had the highest level of mortality compared to the rest of US because that was the hot spot. So this was sort of different in different parts of the country. And from that data, I think what we ended up doing was learning what the risk factors were. And I think the biggest takeaway for us was that the most important thing was patients who are in a remission actually ended up doing well, outside of all the comorbidities. So what is controllable is control of the disease. And in the early days of the pandemic, the thought was, let's stop treatment, let's not see these patients. But the critical piece was controlling that disease and making sure your myeloma patient is in remission would afford them the best outcome from infections from COVID-19 as well. So as I've already mentioned, a lot of bodies helped in this effort, but the IMS was really critical in us trying to come up with an approach to our patients with patient educations and trying to control and making sure that our patients got vaccinated. The IMS did come up with recommendations in the setting of this pandemic, and I think it was really the biggest thing was prevention. Biggest piece was controlling myeloma and finally vaccinating everybody depending on whatever the vaccine available at that particular place and whatever the recommendations of institutional guidelines had to be used. So the good news is we've had lots of different vaccines. India has been at the forefront of actually producing vaccines as well. You know, your next image meeting is in Pune, and Pune has been critical in producing vaccines for the rest of the world actually. What we've used is mRNA-based vaccines, so mostly Pfizer and Moderna was used in the United States, but I know here you had other vaccines available like the AstraZeneca vaccine. So it didn't matter which vaccine as long as you ended up getting vaccinated. And these are some of the vaccines which have been approved based on phase 3 trials for COVID-19. Infectious Disease Society in America has come up with guidelines. These guidelines keep changing, and the guidelines keep changing because this has been moving so quickly. So for example, right now, if we have somebody we have drugs, we have vaccines, and we have antibodies. For drugs, if you have somebody who's COVID-19 positive but not requiring oxygen and can be treated at home, we're using an antiviral called Paxlovid. If a patient has COVID-19 and is oxygen requiring and needs hospitalization, we're using 5 to 10 days of remdesivir. And if they are oxygen requiring, in addition to remdesivir, we are adding dexamethasone. Obviously, everybody is getting vaccinated using drugs like Evusheld. Evusheld was an antibody. It's not that effective with the new COVID variant, because remember, Evusheld was made from the old people who were infected, so they weren't exposed to the new variant. So this is a rapidly moving phase, but this is specifically Evusheld, at least in my experience, has been incredibly important in patients of ours who have Waldenstrom's, for example, who've been on long-term rituximab, and no matter how many vaccine doses you give, these folks absolutely don't mount an immune response. So using drugs like Evusheld has been really important, and in a subset of our patients, specifically post-CAR T cells, we've actually used antibodies to protect them when they couldn't get vaccination. So I think the key points for myeloma is the risk of infection is not necessarily higher, but there is infection, and it could be patients could have a poorer outcome based on the immune system. And if you don't understand this and don't understand the risk and individualize how you're going to take care of this, that can be a problem. I think controlling the disease clone is absolutely critical, and trying to minimize comorbidities. Things like renal failure, etc., makes things worse for infections. These are the ones who can become septic and actually have a worst outcome, is really important. In the setting of the pandemic, the one thing we did see in the United States when we were using masking and social distancing, so last year, not this 2023, but before 2023, our incidence of flu was really low. We started seeing an incidence of flu going up because none of us mask anymore, but masking and social distancing actually did make a difference. And in general, vaccines are very safe. Whether or not they're effective is a debatable topic, and that's why, given that they are safe, I think our recommendations all round, as long as it's not a live vaccine, should be given to all. So I'm just going to conclude by saying the risk of infection is therapy dependent, so understanding that is important. It has to be risk adapted, what kind of prophylaxis you use. We do use, when you see prolonged neutropenia, thrombocytopenia, using growth factor support is critical. Using IVIG is important, and vaccinating everybody is actually critical. What are the unanswered questions? Well, there's not a lot of prospective data in this space, so trying to do that would be good. From a research standpoint, immune monitoring is becoming incredibly important, not just in terms of response to treatment, but also progression of disease. It is critically important looking at this microenvironmental piece, and that's something which is being done in the research setting. And again, lack of data on immunization does exist, and we just use best practice to come up with ideas. So I'll stop here and happy to answer any questions. Thank you.
Yeah, you can ask your questions, please. One or two. Pankaj.
Yeah, so nice talk again. So I did not get it clearly. We have the habit of vaccinating, at the time of diagnosis. What I gather from the talk is that we hold on till they get into remission. I was,
So when they're in remission, your response to a vaccination is going to be better. Yeah. There's data when they're on an immunomodulatory drug that your immune responses are going to be better. But in general, for pneumococcal vaccine, we typically will do it at the time of vaccination. Whether you want to revaccinate when in remission, that may be a good thought. But otherwise all other vaccinations, hopefully doing them in remission, they're going to have a better chance of a response.
Yeah, because in India the patients present quite late, and most of the patients come with infection, and we have seen that in the first 3 months the mortality is quite high in this patient, up to 20%, and by doing vaccination at the time of diagnosis, at least we can reduce some of these infections. Though we need to vaccinate again, yes, you.
So do you all do routine sort of antibacterial prophylaxis to try and...
No antibacterial, but patients who are on renal failure and receiving high dose dex, they generally are put on PCG as well as antifungal prophylaxis till the time they are on high dose dex.
Do you recommend routine here? Yes, sir. Do you recommend routine estimation of immunoglobulins, and if so, how often you do it?
So immunoglobulins we're usually measuring in any case to look at response to treatment. So monthly SPEPs are routinely being done. So when we start seeing IgG levels go down, we typically never used to. With the B cell directed strategies, I think we have become more proactive about using IVIG. But in general, I think we measure that in any case.
I had a question actually for Pankaj and others, that what do you do specifically for tuberculosis prevention, post transplant, or do you look for it?
This is very interesting that every forum actually people ask about the tuberculosis. Somehow in all these patients we have not seen a very high incidence of tuberculosis. Maybe once they are diagnosed, they are kind of in a protected environment and they are taking precautions, and they are not in the community. Probably that may be the reason, but we have not seen a high activation rate of tuberculosis, whether it's a transplant patients or whether they are myeloma patients.
Yeah. The only reason I asked, I had two patients from India, two of those, who actually came for treatment and transplant, and one of them had a resistant tuberculosis developed pre-transplant, and actually we couldn't do transplant. The second one was prophylactically treated soon after, and so 2 out of some sounded like a high number to worry about.
But I think
we are afraid of it, but I don't know, we are fortunate we don't see it, because we are monitoring them and we are always, most of them have already had it, something protects them, we don't know.
So probably that we have a good screening technique, pre-transplant most of us we do CT scans, chest CT and everything, and maybe we screen them out for the transplant, but even in the pre-screening things, we hardly find any patient with the tuberculosis. In our database of across in the image database of transplant, we don't have a single patient with tuberculosis.
Just to add to that, in other malignancies and other hematological malignancies, we did some study when we was at Tata Hospital to see whether there's an increased reactivation while on treatment. No, we didn't.
And if patients have had TB and then you're going to treat them, do you put them on low doses of anti-TB medications?
No.
Once treated, it's fine.
We do not use any INH prophylaxis or anything.
Yeah, and if there are, let's say, the CT scan does show that there are some infiltrates or something like that. So then if we are to give prophylaxis, then it is both rifampicin and INH, because the INH resistance is approximately 20% or so. So there you have to recommend 2 drug combination.
Thank you. So now it's my pleasure to invite Professor Atul Sharma. I don't think he needs an introduction, but he is at IRCH AIMS New Delhi, and he will tell us what is new and are we there for targeted therapy. So what do you? Yeah.
Good morning. Thank you, Hari, for this invitation. Probably the topic is target therapy in myeloma, whether are we there or not. So I'll take back you to the history for many decades. If you see the history for myeloma in last 100 years or so, far more discoveries and understanding has been done in last 25 years. But this doesn't mean that there was none in the previously. Last 70 years prior to that probably laid a strong foundation on which last 25 years discovery has been made. So if you see more number of drugs were investigated or discovered in last 25 years. When I started my career in this oncology, probably sometime early 90s, we were taught the median survival of myeloma patient is really close to 2.5 to 3 years at the max. Transplant was just introduced and this thing. But this cartoon shows you that how we made a progress in last 25 years. If you see really from the 2000 to 2022,